This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in early 2026. It's titled, Speed Matters. Fast-paced 10-meter walking test is superior to normal pace in predicting gait recovery following ventriculoperitoneal shunt insertion in normal pressure hydrocephalus.
This is a topic near and dear to my heart, Alara. We see idiopathic normal pressure hydrocephalus, NPH, every single week in the clinic. We all know Hakim's tetrad: gait disturbance, balance issues, cognitive decline, and urinary incontinence. But let's be honest, gait is the star of the show because it's often the first symptom to show up and the most likely to get better after a shunt.
Exactly. But the million-dollar question in our field has always been, how do we accurately predict who will actually benefit from a VP shunt? We do these temporary CSF diversion tests, lumbar taps or 72-hour lumbar drains, and we watch them walk. But until now, we haven't been entirely sure whether we should be timing them at their comfortable pace or pushing them to go as fast as they can.
Right. If the patient tells me they feel better, but their 10-meter walk time only improved by half a second at a normal pace, I'm often left scratching my head. This study out of the National Hospital for Neurology and Neurosurgery at Queen Square in London really digs into the fast pace versus normal pace debate. Alara, walk us through the methodology.
So this was a retrospective longitudinal cohort study. They followed 125 patients over a significant period, some up to 8 years post-op. Every patient underwent a 72-hour lumbar drainage trial. They performed a 10-meter walking test, or 10 MWT, at 9 different time points: before the drain, after the drain, immediately after the VP shunt, and then at various intervals from 6 months all the way to 8 years.
That's a massive amount of follow-up data. Usually, these studies stop at 6 months or a year.
It really is. And at each of those time points, they did 2 tests. First, the normal pace, walking as if they were going to the shops. Second, the fast pace, walking as fast as they safely could. They measured 2 things, the time taken and the number of steps.
And what were they looking for specifically in terms of a response?
They defined an early responder to the lumbar drain as someone who either improved their walking pace by at least 0.1 meters per second or reduced their step count by more than 10%.
Okay, so let's get to the meat of it. We've all been in the hall with a stopwatch. What did the data show? Does speed actually matter?
It matters significantly. The results showed that while both normal and fast pace improvements were maintained for about 2 to 3 years post-operatively, the fast pace test was a much stronger predictor of who would benefit from the shunt long-term.
Give me the numbers. How much better was it?
If a patient was an early responder on the fast-paced time test, they were 3.91 times more likely to benefit from the surgery. Compare that to the normal pace time, where the odds ratio was only 2.64. But here's the kicker. The most predictive metric of all was the fast-paced step count. If they improved their step count at a fast pace after the lumbar drain, they were 6.29 times more likely to have a good surgical outcome. For normal pace steps, that odds ratio was only 1.93.
Wow. So the fast-paced step count is nearly 3 times as predictive as the normal pace step count. That is a huge clinical pearl. Why do we think that is? Why does fast tell us more than normal?
The authors suggest it comes down to gait automaticity and executive control. When we walk at a normal, comfortable pace, it's largely an automatic process, but NPH patients often lose that automaticity. When you ask them to walk fast, you're challenging their gait reserve. It requires more executive function and motor planning. If they can tap into that reserve after we drain some CSF, it shows that the underlying motor pathways are still salvageable.
That makes perfect sense. It's like a cardiac stress test, but for the brain. If you just look at the heart at rest, you might miss the pathology. You have to stress the system to see the compensation.
Exactly. And the study also addressed a common clinical headache. What do you do when the results are contradictory?
Oh, I see that all the time. The patient's normal pace is slightly slower after the drain, maybe they're tired, but their fast pace is significantly better, or vice versa.
The authors were very clear on this. When the results conflict, the fast pace outcome should take priority. If they show improvement in the fast pace test, they are likely a good candidate for a shunt, even if the normal pace test is unimpressive.
That's a very practical takeaway for the residents listening. Don't just look at the comfortable walk. If you aren't pushing them to their maximum speed during the assessment, you might be underdiagnosing shunt-responsive NPH.
And let's talk about that 0.1 meters per second threshold. For the junior residents, that might seem like a small number, but in the world of geriatric gait, it's a clinically meaningful change. It's the difference between being household bound and being able to cross a street before the light changes.
Right, and the step count is equally important. In INPH, we often talk about the magnetic gait, or petit pas, the small, shuffling steps. If the lumbar drain allows them to increase their stride length, their step count drops. Seeing that happen specifically at a fast pace tells you the frontal circuits are responding to the pressure change.
One thing I found interesting in the study was the long-term data. They noticed that the benefits of the shunt tend to plateau or slightly decline after the 3-year mark.
Which is consistent with what we see in practice. These patients are older. They develop comorbidities, osteoarthritis, sarcopenia, or perhaps concurrent neurodegenerative diseases like Alzheimer's. But even so, the fact that a 72-hour drain can predict a 3-year benefit with such high odds ratios is a testament to why we do this.
So, Dr. Aris, how does this change your Monday morning clinic?
Well, for one, I'm going to be much more insistent that the physical therapists or the residents performing the 10-meter walking tests are strictly recording the fast pace, and I think I'll stop being so conservative with patients who only show improvement on the fast-paced portion. Before this, I might have been hesitant to offer a shunt if the normal walk didn't change. Now I have the evidence to say speed matters.
It's also a great reminder to count the steps, not just look at the stopwatch. A patient might walk the 10 meters in the same amount of time, but do it in 5 fewer steps. That's a success.
Absolutely. A lower step count means better stability and better stride length. So to summarize for our listeners, in INPH workups, the 10-meter walking test at a fast pace is the superior predictor for VP shunt success. Look for a 0.1 meters per second improvement in speed or a 10% reduction in step count. If the fast and normal paces don't agree, trust the fast pace.
And remember that the fast-paced step count is your strongest predictor, with an odds ratio of over 6.
Great stuff, Alara. This is the kind of study that really refines the art of neurosurgical decision-making with solid data.
Definitely. It's a win for the patients and a win for clinical clarity.
That's all for today's episode of the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. Keep walking fast, and we'll see you in the next episode.
Stay sharp.